Welcome. My name is Jennifer Myers, and I'm the Assistant Director of Campus Mental Health Initiatives. And I was asked to speak to you about youth suicide prevention for public health professionals. And youth suicide prevention in this situation would involve family members and communities in all different levels of suicide prevention that could target the youth. I know many of you may be involved in public health in a variety of different ways. So I hope to give you some information that you find to be useful in your area, but it may also require you to think more critically about how this may apply if you're not specifically involved in youth or if you're doing more environmental strategies. This is part of the reason why I do what I do, is because we have some things to battle when it comes to mental health and suicide prevention, as there's some stigmas to talk about it. So hopefully we, as public health professionals, work hard to battle the stigma that may be related to depression and mental health concerns, including suicide prevention. Here's a little bit of what we're going to cover today. Just going to cover some statistics about suicide, an overview of suicide risk, including warning signs, risk factors, and protective factors, and then cover some prevention principles. This is a screenshot here. I left the link on there so that you could look it up also. But basically this covers the leading causes of death here in the United States. This is the specific data for South Carolina. So in South Carolina, we had 673 suicide deaths in 2012, which is the most recent suicide death data that we have at this time. It puts the death rate, which is usually per 100,000, so that's 13.7 per 100,000 individuals, and ranks us about 27th in the nation. Although the U.S. rate is 12.6 per 100,000. So you can see we're slightly above the rate. If you look at suicide deaths in the United States, and this is the whole entire United States, this again is that rate per 100,000. And this has the total there in the middle. You can see that men die by suicide at a greater rate than females die by suicide. This was not in a chart form, but what we also know is that our transgender and gender nonconforming individuals are also at higher risk for suicidal thinking and behavior. We don't track suicide death rate because transgender and gender nonconforming are not included in the death certificate and mortality data. You might also look here at the suicide and homicide rates in the United States, and this is true for South Carolina also, that typically suicides are about twice the number of homicides here in South Carolina. I've included information from the Youth Risk Behavior Survey, and I've included the link here for you to look more at the information. There are multiple slides to the Youth Risk Behavior Survey, and it's a great resource for getting information about what may be occurring in your area and in the state, specifically of South Carolina. So you can see this is South Carolina high school specific information. And this is the percentage of students who'd been threatened or injured with a weapon, such as a gun, a knife, or club on school property more than once in the past 12 months. So this is specifically on school property. But you see about 6.5 of our students who have faced a situation where they've been threatened or injured with a weapon. Then you look more here at students who had felt sad or hopeless almost every day for more than 2 weeks, typically about the criteria for what we look for a major depressive disorder. And you have about a quarter of those students. And you can see the difference in the grades and differences in different racial and ethnic groups as to where there may be some more significant concern in depression. When you think about public health for mental health and suicide prevention, we think about, are we catching and are we identifying about a quarter of our students who might be feeling sad or hopeless almost every day, nearly every day. We also think about how this may affect someone academically and in the home and what other things may be contributing to this. Then you have here the students who have seriously considering attempted suicide in the past 12 months. So you have about 13.2% of students seriously considering attempting suicide, with that risk being slightly greater in 9th grade in the younger years, and then increasing or decreasing throughout high school. You have the percentage of students who made a plan about how they might attempt suicide. And again, about 12%. So one could assume that a larger number of the students who are seriously considering suicide may also be making a plan. This would show a greater risk for youth here. And this is those who've actually attempted suicide one or more times in the past 12 months. So you have about 9.4% of our students who have attempted suicide or have reported that they've attempted suicide. Now, this is a self-report measure. We do ask another question about how many people had been received treatment for a suicide attempt. And if you think about suicide prevention, one of those at greater risk groups for dying by suicide is those who have attempted suicide. So this is actually an interesting group in two different ways. One is to consider, can we treat those who are struggling with major depression or other mental health issues prior to the point of them getting to a suicide attempt, including those who are considering suicide? Can we identify and treat those in such a way that we don't, people don't enter this risk group? The other thing is out of these 9.4%, how do we wrap them around with services so that we can help increase those protective factors that I'll talk about later to decrease their risk throughout their life? This is what I was talking about with those who have been treated. So about 4% of students said they'd made a suicide attempt and were treated by a doctor or nurse. Now, the same information can be accessed for middle school students, and you see about 21% of middle school students saying they've seriously thought about killing themselves. I include this to show that there really is no group that's immune from suicidal thinking, whether that be someone who's very elderly and potentially having a lot of support surrounded by them, or even seem to be wealthy or have other things that may be looking very good in their lives, to someone who may be quite young. So it's important to think about suicide prevention with all genders, all age groups, all racial groups, all ethnic groups, all spiritual groups, those types of things, to make sure that we're not missing any risk that may be out there. If you look here, this is those who've made a plan, about 14% of our middle school students, and this is the same information but focused on middle school of students who've ever tried to kill themselves, with about 9% trying to kill themselves. And again, if you think about this as being a group that we could potentially prevent people from entering this percentage, we could potentially prevent increased suicide risk over a period of time. So if we look at suicide prevention efforts from a public health perspective, most of you as public health professionals know that strategic planning is very important. So it should begin with identifying specific risk and protective factors for intervention specific to the population that you're working in. That's why I mentioned getting creative or critical thinking in where are you working in your area, and how can you include suicide prevention in what you're doing. And I would, especially because suicidal thinking and mental health issues are so pervasive, or can be pervasive in our community, with many people battling mental health concerns, and obviously with youth here having a percentage of students who are seriously considering suicide, any interaction you're having with youth or families could include mental health interventions, and specifically public suicide prevention interventions. So let's define risk factors, protective factors, and warning signs as it relates to suicide risk. So these are risk factors are personal or environmental characteristics that may be associated with suicide. And some of these things may be things that may be modifiable and some may not. We talked about gender earlier. Male gender may be a risk factor more for suicide that is not as modifiable as making interventions in a community to decrease abuse, whether that be sexual abuse, physical abuse, or other abuse. That would be a risk factor that could potentially be modifiable. Protective factors are things that protect someone or reduce the chance of suicide, whether that be personal or environmental characteristics. And then warning signs are signs that indicate someone might be in danger of suicide, acute danger, short-term risk. We'll go into defining these more specifically here. So some things to remember is risk factors are not warning signs. They're not exactly the same. And not all risk and protective factors are equal, meaning that some may be more powerful or important to focus on than others. So those major risk factors tend to include those prior suicide attempts that I mentioned earlier, mood disorders, substance abuse, and access to lethal means. The other major protective factors include effective mental health care, connectedness, problem-solving skills, and contacts with caregivers. Other things to remember is that suicide and protective factors provide those public health targets for intervention, both in individuals and communities. So as we go through these risk factors and protective factors, one thing you might think of is what can I do in my area to either decrease the risk or increase protective factors to address suicide prevention in my area. It also varies across individuals and across settings. So what may be a significant risk factor in one area may not be quite so much in another population or group. One thing that I think is really important for public health professionals to know is the individual warning signs of suicide risks. These are specific to an individual, and as a public health professional, it's important for you to know these warning signs, but also to teach others around you the warning signs of someone who might be suicidal and how to intervene. That includes other colleagues, family members, teachers, other professionals. So we look at ideation as suicidal ideation, which is thinking about suicide. We know someone's thinking about suicide because often they may talk about it. They may say things like, I wish I were dead. I wish I wasn't here. I don't want to be alive any longer. No one's going to see me anymore. I'd rather be in heaven. I'm going to kill myself. Those are statements of suicidal ideation. Sometimes these are posted on social media, Facebook, Instagram, Twitter, other types of social media. Sometimes they're texted. Sometimes they're written in an email. But yet these are still suicidal ideation. I would think of as the fire alarm going off. We wouldn't ignore a fire alarm going off. So if you hear a suicidal thinking or a suicidal statement, it's important to connect that person to emergency services and get a mental health evaluation as soon as possible and to help them stay safe in that process. So if it was a young teen at home, the thing to tell the family would be to stay with the teenager until they're able to either get them to an emergency room, an urgent mental health clinic, use a community mental health center, or the other resource that's good to use over the phone if you cannot reach anyone in person other than calling 911 is the National Suicide Prevention Lifeline, and their number is 1-800-273-8255. The other warning signs to look for is an increase in substance abuse. Usually this is specific to that person. Some people have belief systems where they don't use substances at all. If they start using any substance at all, that's an increased risk. For other people, that may be something very different for them. Substance addiction also could be a risk factor, but in this situation, we're talking about increased substance use. Purposelessness, talking like my life has no purpose. There's no point in going on, no point in trying. Anxiety can also be troubles with sleeping, and agitation, significant kind of psychological pain that may occur. The significant anxiety that, unremitting psychological pain. Feeling trapped, like there's no way out. Feeling like suicide may be the only option. You start hearing the words only, or I can't, or I never. Hopelessness. People may have something planned for the future, but they may not have any hope that it's going to work out for them, that things are going to improve. Withdrawal or isolation. Withdrawal, not engaging in activities, not connecting with people, isolating from groups and communities. Anger. Sometimes people seek revenge through suicidal behavior, and it's important to look at. I think also sometimes we can miss anger because we can think that someone is just, they'll get over it. So anger is something to look for also. Recklessness, maybe mixing drugs or alcohol that wouldn't normally obviously be mixed. Driving recklessly. Recklessness can also be recklessness with sexual behaviors, finances, those types of things, but engaging in reckless behaviors. And mood changes. And mood changes are specific to that person. meaning that depression is not always the main sign to say that someone is thinking about suicide. Sometimes people appear to have a mood change where they shift to be potentially manic or happier or just more engaged. So it may be something to look for, not just signs of depression. If you see any of these other warning signs other than the first one, suicidal thinking and ideation, then it's important to check in with the individual and whoever has a relationship with them and ask them, are you thinking about suicide? And to do so in a kind, caring, private, and confidential way. So to bring them either in, or if sometimes people do this via electronic communications nowadays, youth do this with each other sometimes, but even checking in and saying, I've noticed things have been different for you lately. I notice you're saying things that it feels like things aren't going to get any better for you. Sometimes when people say things like, there's no point in trying, or things aren't going to get any better, they think about suicide. Have you been thinking about suicide? These are some of the risk factors to look for. Disorders, mental health disorders, substance use, conduct or disruptive behavior disorders, anxiety disorders, previous suicide attempts, and self-injury. And previous suicide attempts is quite, stands out more than self-injury. The presence of multiple behavioral health disorders, the combination of different behavior problems and substance use really increases the suicide risk, which is why it's important to intervene on all of those levels. We have additional personal characteristics, and we've commented on a few of these here. So we'll just look at, low self-esteem, lack of self-acceptance, specifically lack of belongingness. The other thing on here is the perception of being a burden. Thomas Joyner has an interpersonal theory of suicide risk, and he would reference the lack of belongingness, a perception of not belonging, and a perception of being a burden as being two things that might come together to make someone desire to die by suicide. We've talked a bit about impulsivity and risk-taking. The other things on here are poor problem-solving skills or coping skills. So one thing when you look at as a public health professional, we'll talk about in just a little bit, is what you might do is build problem-solving or coping skills, therefore reducing risk factors. Other life circumstances to look for, specifically things that may trigger a crisis for someone. These are specific to youth, interpersonal problems, legal problems, school or work problems, abuse, with sexual abuse showing a higher suicide risk than other forms of abuse, chronic illness or disability, especially if it's a significant change for that person, and exposure to suicide of a peer, which is why it's so important to do what's called postvention, which is after a suicide death has occurred, to take care of the community that may be impacted by a suicide death. You have other family characteristics, specifically a family history of suicide. Those who have lost a family member to suicide are about 2 to 3 times greater risk than the general population to die by suicide themselves. You have other parental mental health problems, divorce, death, and then a variety of different problems in parent-child relationship that can occur. And environmental factors, things that can be going on in the environment that may increase someone's risk. And then some of this has to do with acceptance and inclusion of all people, respect and treatment of all cultures, all racial groups, ethnic groups, spiritual belief systems, gender identity, sexual orientation, of all the different things that may be occurring in someone's life, physical characteristics, ability levels, and those such things. Then you also have, the school environment, but access to lethal means really matters. And so when you think about this as a public health professional, one environmental strategy that can be done to prevent suicide is to reduce the access to lethal means, which includes guns. And so reducing the access to lethal means doesn't necessarily mean that you have broad strategies for ridding the community of guns. What it may mean is paying attention to those who may be at greater risk. If a mom has recently had a child and may be suffering from postpartum syndrome, does she have access to a gun? If a student is showing warning signs of suicide, or if a parent is showing signs of depression or other mental health issues, do they have access to a gun? And the Suicide Prevention Resource Center, I've linked to this training at the very end, has a training specifically called Counseling on Access to Lethal Means that helps someone reduce access to lethal means in those situations. Now, this also means having safe communities where there are limited access to firearms, but it also means medications, bridges, parking garages, buildings, anything that has something like that has window locks and restrictions and barriers to prevent suicide risk. The other environmental strategy here is in mental health care. The more someone has access to care, the better, earlier we can intervene and decrease their risk. These are protective factors. So these might be the things that you would want to build in a community in order to decrease suicide risk. So you want to build resiliency. You want to build self-esteem. You want to get people engaged in activities, whether that be spiritual or physical activity. You want to build emotion regulation and acceptance of all body images and self-care. Other protective factors that you might want to build in the community is problem-solving skills, coping skills, especially nonviolent handling of disputes. So you can think about this in the family environment, the school environment, but also any community setting. As much as you can build on these protective factors, you can also decrease suicide risk. These are additional protective factors: supportive family, connectedness to them, close friends, family and school support. And there is one of the best practices within the best practice registry for the Suicide Prevention Resource Center is something called the Family Acceptance Project, which is accepting lesbian, gay, bisexual, and transgender individuals. And that has been shown to reduce suicide risk within that community. So it's important to think about the community-specific protective factors that may be going on. Some of these seem to make sense with a school setting, but basically the more someone has a better academic achievement, a sense of connectedness, respect for all cultures, a safe environment, and a close community, which are all things that can help reduce suicide risk, and things that as a public health professional you might think of: how can I intervene in these areas? These are additional protective factors: access to effective mental health care, access to medical care, and then access to means, which is important, specifically with youth. The research is that youth tend to know where the guns are stored, where the ammunition is stored, and where the lock is. So it's important to make sure that not only are guns locked or unloaded and stored appropriately, but that they're also done in a way in which the youth can't just go and find it very easily, along with restricted access to alcohol specifically for youth. When you think about suicide prevention principles, we think about universal prevention, which just should make sense to most of you as public health professionals. We want to target all population members regardless of risk. One strategy might be a suicide prevention gatekeeper training, and there are some through programs like Question, Persuade, Refer, or Safe Talk, or the American Foundation for Suicide Prevention also may have some information about suicide prevention gatekeeper trainings, where you teach anyone in a community the warning signs of a suicidal person, how to ask about suicide, and where to refer them. So that may be a universal prevention strategy. Environmental prevention strategies are universal prevention strategies. Resiliency programs are universal prevention strategies. Selective prevention gets into members who are specifically at elevated risk. So this may be doing mental health screenings to identify those who may be at greater risk. And then you have indicated prevention, basically, where you're going to target those who are suffering, such as providing treatment to those with major depressive disorders or wraparound services to them. When we think about upstream suicide prevention, actually thinking about intervening really early in someone's life. So basically, upstream suicide prevention is preventing the causes that cause suicide. So can we prevent substance abuse? Can we prevent abuse in a family? Can we prevent some of the mental health concerns or increased resiliency? So basically, what can we do early on? You can even do this in elementary schools, and that's actually what some of these ideas are, is reducing risk factors by teaching coping skills in elementary schools. And there's a good behavior game that has had some research behind it, an article I've linked to learn more about the good behavior game that could be used in elementary schools, that has some evidence behind it in reducing suicide risk later on in life. And yes, that research is from 1969. There is a longitudinal study that's when the game was created, and there's a longitudinal study that's been followed for many years And more, you can learn more by accessing the link there. Providing substance abuse prevention programs, support for people in transition, divorce, retirement, unemployment, adulthood, leaving the military, a new child in the family, if a death has occurred, any of those things, moving into a new community. We have a lot of military bases here in South Carolina, moving from one community to another, those transitions. And so that's something you can think about in a field that you're in, the area that you're in. Other upstream interventions might be enhancing protective factors, offering healthy parenting programs, incorporating emotional regulation training into school classrooms, providing recreational programs for older adults. When we look at other suicide prevention strategies, you look at midstream interventions. Those are the ones that are, basically there's some risk factors already present in people's lives and kind of protect them from the effects of those risk factors. So this might be that early detection, screening for depression and other mental health illnesses. This is something you might think about doing in the area that you're in. Are we screening for substance abuse also? The screening, brief intervention, and referral to treatment model is a great model, and you can look up more about that also, but that's a great model for substance abuse using motivational interviewing strategies. Activities that encourage people to seek help. So basically normalizing, battling that stigma. And you can do this through social norming campaigns also. We can do this on our campus knowing that about 10% of our students utilize the counseling center services in any given year. It's kind of 1 in 10 students. That feels a lot more normal than to think that I'm the only one doing it. Downstream interventions might be targeting people who are already involved in suicidal behavior, someone who's attempted suicide or experiencing suicidal ideation. This could be specific therapy models, but it could also be safety planning. And Barbara Stanley and Greg Brown have created a great tool for safety planning that can actually be accessed through some of the training links that I have at the end, also through Zero Suicide and the Suicide Prevention Resource Center. When you look at youth suicide prevention, specifically this toolkit is, I would recommend it for anyone, even if you're not in a high school. It's about 230 some pages, and it really breaks these protocols down for responding to suicide deaths, for intervening with those who may be at suicide risk. It also breaks down the education and training for staff that you can provide, parent education, student education, and screening. It provides sample letters that you might send to parents. Whenever you're looking at youth suicide prevention, it's important to train the professionals, the parents, the caregivers, and then the students. Even though peers, high schoolers and middle schoolers are more likely to go to peers, you want to make sure that when they go to an adult, that adult doesn't then drop the ball because they're not trained in risk. I would highly recommend using that Preventing a Suicide Toolkit for high schools. And if the link is not accessible through the portal here, you can just Google those words with the Substance Abuse Mental Health Services Administration, and you can pull it up for free to assist you. It's a very specific toolkit. Other toolkits and trainings and resources that are available are through the Suicide Prevention Resource Center, and you can look at how to access data, evidence-based, the public health argument for suicide prevention, counseling on access to lethal means through the Suicide Prevention Resource Center training here, also through a variety of other links here. So I would encourage you to look at them. There are other trainings on the Zero Suicide page. There's free resources that you can order through the National Suicide Prevention Lifeline, the Substance Abuse Mental Health Services Administration, in different languages. You can order warning signs, cards, posters, things that you can put out into your community. There's books, toolkits to help you with substance abuse and suicide risk prevention strategies. So I would encourage you to look through these things. Live Through This is a great website that's been created by those who have attempted suicide to encourage people to resiliency and to battle through those different challenges that they may have. Postvention is specifically after a suicide death, and they can really impact families and communities quite significantly, and high schools quite significantly. So these are some specific toolkits that you can be accessed for workplace, colleges, universities, and high schools for preventing or for responding after a suicide death. There's also a resource and healing guide for individuals who may be coping with a suicide loss. If there was a suicide loss in a family that you might be working with, the American Foundation for Suicide Prevention also offers support groups throughout the state that might be really good to access. So what I encourage all of us to do is to really include suicide prevention and mental health in all the different areas of public health that you're looking in, to look at, do I want to do upstream prevention strategies even before there's any concern, to build those coping skills and resiliency and emotional regulation that help people to cope? Or do we want to implement mental health screenings and referral to treatment for substances or for mental health concerns, to intervene earlier before suicide risk occurs or before suicidal attempts occur? And if you can reduce attempts, you can potentially reduce suicide deaths also. Or do we want to make the environment safer? And making environment safer actually has been proven multiple times in helping to reduce suicide risk. So do we want to reduce access to guns or medications or alcohol in the areas that we're in the community that we may be working in, the family that we may be working in? So what I encourage everyone here is to really include mental health and suicide prevention in the area that you're in. I hope that you listen to this and say, you know what, I'm going to take some of these risk factors or protective factors and really learn more. Or I'm going to memorize the warning signs of a suicidal person so that I'm able to identify that in my day-to-day activities, especially if about 12%, 13% of our high school students are seriously considering suicide, about 21% of our middle school students, and probably about 6 to 8 of the percent of the general population may be considering suicide. You're going to run into suicidal people, making sure you know how to recognize them and refer them to appropriate care, and that you have protocols within your workplaces to do so. I appreciate your time today. If any of you have any specific questions for me, you can access me through email at jenmyers @mailbox.se.edu. It's on that first slide there. I appreciate your time. Thank you.